everyone, welcome back to the channel. Today we will dissect another interesting topic, osteomyelitis. The very name osteomyelitis gives us some really big clues about what's going on. Let's break it down piece by piece. Osteo, simple enough, that just means bone. Myelo, this refers to marrow, specifically bone marrow. Itis, and that's telling us there's inflammation. So if you put it all together, osteomyelitis literally means inflammation of the bone and bone marrow. Before diving deeper into how osteomyelitis works, let's take a closer look at the basic anatomy of a bone structure. For example, we will choose a typical long bone, such as the shin bone. On the outside, we have the tough fibrous layer called the periosteum. Think of it as the bone's protective jacket. It's rich in blood vessels and nerves, and crucially, it contains cells vital for bone growth and repair, especially after a fracture. Just underneath the periosteum is where the real density lies, the compact bone, also known as cortical bone. This is the super hard outer layer that gives bones their incredible strength and rigidity. If you could zoom in, you'd see it's made of tightly packed cylindrical units called osteons. Each osteon is like a miniature column designed to resist bending and compression, perfect for bearing weight. Now, if we move further inside, especially at the ends of long bones and within bones like your vertebrae, you'll find the spongy bone, or cancellous bone. As the name suggests, it looks a bit like a honeycomb or a sponge. It's made of a network of tiny interconnected beams and plates called trabeculae. Furthermore, the spaces within this spongy bone are often where you find that amazing bone marrow, busy making your blood cells. Osteomyelitis is an inflammatory process happening in the bone and bone marrow, typically kicked off by tiny microbial invaders. The most common way this happens is through hematogenous dissemination. This is where tiny bugs, usually Staphylococcus aureus, hitch a ride in your bloodstream from an infection somewhere else in your body. This pathway is especially common in kids, where it loves to hit the metaphysis of their long bones. Why there? Because those areas have a really rich blood supply, but the blood flow is a bit sluggish, which creates a perfect little hangout spot for bacteria to settle in and deposit themselves on the bone tissue. Picture a 5-year-old boy who just had a nasty skin lesion on his arm. A week later, he starts limping and complaining of really bad pain in his thigh. What's likely happening here is bacteria from that skin infection traveled through his bloodstream straight to the fast-growing part of his femur, starting up that osteomyelitis. Sometimes, though, the infection comes from contiguous spread. This means direct contact, like from an open fracture, a penetrating injury, or even during surgery where microbes get straight into the bone. Think about a motorcyclist who sustains an open tibia fracture in a road traffic accident. Even after they clean it up, environmental bacteria from the crash scene could directly contaminate that exposed bone, leading to osteomyelitis right where the break is. Diabetes is another way of contiguous spread. Diabetic osteomyelitis is a severe bone infection that results from a specific sequence of diabetic complications. Diabetic neuropathy causes a loss of protective sensation, which allows minor foot trauma to go unnoticed. This often leads to a persistent plantar ulcer. Poor blood flow from peripheral arterial disease and a compromised immune system further impedes wound healing and allow bacteria to flourish. The infection then spreads by contiguous extension from the ulcer's soft tissue directly into the adjacent bone. Once those pathogens colonize the bone, they kick off a massive inflammatory response. If we move further into the details, we can see how the pus is formed by neutrophils and the macrophages that isolate the causing pathogens. This buildup of pressure inside the bone can actually cut off the delicate blood supply, leading to localized ischemia, meaning lack of blood, and eventually necrosis or death of the bone tissue. This dead bone forms a piece we call a sequestrum. Sounds fancy, but it's just dead bone. The periosteum, that outer bone covering, often gets lifted up by all that pus, and then it tries to lay down new bone, creating an involucrum, which is like a new bony sheath around the dead bone. This whole complex changes the bone's architecture and makes it really hard for antibiotics to get in and for your immune system to fight the infection, which often makes it a long-term problem. Sometimes the pus even tunnels its way through the bone and soft tissues, forming sinus tracts that drain outside the body. When we talk about chronic osteomyelitis, it's usually a persistent infection with symptoms that come and go. the presence of those sequestra and involucra makes these infections incredibly stubborn and hard to treat. So, how do you actually spot osteomyelitis? Well, the way it shows up can be really different depending on how quickly it came on, which bone is affected, and how strong the patient's immune system is. There are two possible phases of osteomyelitis. Acute osteomyelitis usually hits fast with general signs of infection and a lot of localized bone pain. You'll often see fever and chills, a clear sign the body's fighting something big. Patients usually feel profoundly tired and generally unwell. There's almost always localized pain over the affected bone, and it can be excruciating, often described as throbbing and getting much worse with movement or weight bearing. The soft tissues right over the infected bone might look red, feel swollen, and be very tender to the touch. In more severe cases, you might even be able to feel a localized abscess. Now, chronic osteomyelitis often creeps up slowly. It's the sneaky kind. Patients might just have persistent or on and off bone pain for ages. A classic sign of chronic osteomyelitis is often a draining sinus tract. It'll intermittently ooze pus or bloody fluid. This is essentially the bone crying for help, literally. Sometimes there are quiet periods followed by sudden flare-ups that can feel just like acute osteomyelitis. In some cases, you might even notice some swelling or tenderness, but it's usually not as dramatic as in the acute cases. Diagnosing osteomyelitis is often a puzzle, and it requires piecing together clinical clues, lab results, and imaging studies. First off, we always start with a good clinical history and physical examination. We'll ask about the patient's symptoms, any recent injuries or surgeries, and their medical history, especially conditions like diabetes or immune suppression. On examination, we're looking for those signs we just talked about: tenderness, swelling, redness, and especially any draining sinus tracts. Next, we move to the laboratory tests. We'll almost always order blood work. We're looking for signs of inflammation like an elevated white blood cell count and increased erythrocyte sedimentation rate and C-reactive protein. These are non-specific markers of inflammation, but if they're high, it definitely raises our suspicion. The real game changer for identifying this specific bug is getting microbiological cultures. This means taking samples directly from the infected bone, usually through a bone biopsy, surgical or percutaneous. Pay attention. Getting pus from a draining sinus tract isn't always reliable because it can be contaminated with skin bacteria. But a bone biopsy gives us the best shot at identifying the causative organism. Then we bring in the big guns, imaging studies. We usually start with plain x-rays. Now here's the kicker. Early in acute osteomyelitis, x-rays might look completely normal. It often takes about 2 weeks for changes like periosteal elevation or bone destruction to show up. For better sensitivity, especially in early or tricky cases, we rely heavily on magnetic resonance imaging. MRI is fantastic because it shows us bone marrow edema, soft tissue involvement, and abscesses much earlier than x-rays. It's like having x-ray vision, but for soft tissues and early changes. Treating osteomyelitis is a big deal. It usually needs a combined approach, often involving both medication and surgery. Antimicrobial therapy, this is absolutely foundational. We usually start with empiric antibiotics based on what bacteria are most likely the culprits. For instance, Staphylococcus aureus. In this particular case, when we know the causing factor, we can use a combination of B-lactams and vancomycin, which have a really large spectrum of action. In other cases, once we get culture results and know exactly what we're dealing with, we tailor the antibiotic choice. We give high doses of antibiotics, typically intravenously, for several weeks or even months to make sure they really get into the bone and completely kill off the infection. To check if the infection responds to therapy, we can evaluate the ESR level. The treatment duration can be anywhere from 4 to 6 weeks for acute cases to several months for more chronic or complicated infections. Surgical intervention. This is often essential, particularly in chronic osteomyelitis or acute cases where there's a lot of pus or dead bone. Debridement. This is where the surgeon goes in and removes all the dead bone, that's sequestrum, any infected soft tissue, and any foreign objects. Getting rid of all that infected material is absolutely crucial so antibiotics can work and the bone can start to heal. Drainage. If there are abscesses or collections of pus, we cut into them and drain them to relieve pressure and reduce the bacterial load. And that wraps up our overview of osteomyelitis. If you found this information helpful, please give this video a like, subscribe to the channel for more health insights, and let me know in the comments what other topics you'd like me to cover next. Thanks for watching, and we'll see you in the next one.